Hello everyone, I'm Dr. Sonali Senapati, GR3 Radio Diagnosis, and under the guidance of Dr. Pramod Kumar, Professor Radio Diagnosis, Rohilkhand Medical College, I'm presenting a paper on the topic USG and MRI Correlation in Evaluation of Meniscal Lesion of Knee. Knee, as we know, is a complex and commonly injured joint with a combination of deep and superficial structures which can be affected by a wide range of pathological conditions. The primary advanced modality for evaluating knee joint conditions is MRI, given its high tissue contrast and ease of diagnosing intra-articular pathology. However, MRI can be quite costly, and some patients are unable to undergo MRI evaluation due to certain implanted devices. Ultrasound is a cost-effective alternative in such cases, which can be performed in point-of-care settings to evaluate many superficial and some internal structures of the knee. In addition, ultrasound is often the preferred imaging modality for therapeutic intervention and dynamic imaging of the knee. However, despite its wide availability, it is operator dependent and has limited utility for evaluating deeper structures and certain cartilage compartments. The aim of this study was to compare these two modalities, MRI and USG, with arthroscopic results in cases of meniscal injuries and assess which modality provides a better sensitivity and specificity. The study was conducted involving 50 patients who were referred to the Department of Radiodiagnosis with a history of knee trauma or suspected knee meniscal lesion. These patients were selected based on significant clinical histories and evaluation that indicated a potential meniscal lesion in the knee joint. The study was aimed to compare the diagnostic accuracy of ultrasonography and MRI in detecting meniscal injuries, and findings from these imaging techniques were compared and correlated with diagnostic arthroscopy, which served as gold standard. Inclusion criteria included patients with knee trauma or symptoms suggestive of meniscal injuries, patients aged 18 to 65 years with no previous knee surgeries. And exclusion criteria was patients with prior surgeries on affected knee, patients with contraindications to MRI, or patients with other knee pathology which could affect the diagnosis of meniscal lesion. First clinical examination was performed in all the patients, including physical examination, assessment of knee symptoms, and history of trauma. And clinical tests such as McMurray test and Apley's test was performed. After which, the patient underwent diagnostic imaging using 1.5 Tesla and 0.4 Tesla machine, and standard protocol for knee imaging was performed with specific focus on meniscal lesions, including sagittal and coronal planes. A variety of imaging sequences were obtained to ensure comprehensive evaluation of knee joint. And then USG was performed using a Samsung HS40 linear probe with a frequency range of 7 to 13 megahertz with particular attention to the menisci. It was performed in dynamic position to visualize any tears or abnormalities, and procedure was involved placing transducer longitudinally along the knee joint on both medial and lateral sides while the patient was positioned in prone position. It allowed visualization of femoral and tibial condyles with meniscus situated in between them. Then arthroscopy was performed under spinal or epidural anesthesia with complete sterile precautions. The procedure was performed using standard anteromedial and anterolateral portals with visualization to a 30-degree camera. And intraoperative video capture devices were used to record all the arthroscopic images for documentation. And then data analysis was performed. Sensitivity, specificity, positive predictive value, that is PPV, and negative predictive value, that is NPV, of MRI and ultrasonography was calculated and compared, and statistical analysis was then performed using appropriate software. Coming to the results, out of 50 patients, a total of 100 menisci was examined, and after confirmation to arthroscopy, 34 meniscal tears, 3 degenerative tears, and 2 meniscal cysts not associated with tears were identified. These findings allowed for comparison between sensitivity, specificity, positive predictive value, and negative predictive value, and accuracy of ultrasonography and MRI using arthroscopic results as a reference standard. Only grade 3 tears were considered positive, grade 1 and 2 tears were categorized as no tear and taken as negative. And the data was then analyzed using two positive, two negative, false negative, and false positive values, and separate tables and charts were drawn for medial meniscus, for lateral meniscus, and combined total to compare the diagnostic performance of both the imaging modalities. These are some of the images obtained. This MRI shows a grade 3 hyperintense signal in the posterior horn of medial meniscus, suggestive of tear. Here we can see the lateral meniscus at grade 3 and grade 3 tear in the posterior horn based on ultrasonography. Here arthroscopy images show superficial tears of lateral meniscus, and on the right hand side we can see a lesion, no meniscal tear. These are some of the images obtained from a patient who presented to us with knee pain and underwent ultrasonography, MRI, and arthroscopy respectively. The images that we see here show a lateral horn tear on USG. These are the results that we found, which are tabulated according to the accuracy, sensitivity, specificity, positive and negative predictive value. Here we can see that the accuracy and sensitivity, the specificity and PPV and NPV of medial meniscus, of lateral meniscus, and the total medial and lateral meniscus comparison has been given in this table, and this accuracy is comparable. However, in all of these findings, we can see that accuracy, sensitivity, specificity, PPV, and NPV of MRI is slightly better than USG. The conclusion that we draw from these tables is that while ultrasonography demonstrated comparable specificity to MRI in diagnosing meniscal injuries, its lower sensitivity suggests a need for further refinement to reduce false negative diagnosis and to prevent unnecessary arthroscopies. Despite this limitation, it can effectively be utilized as a screening tool before arthroscopy, particularly in situations where MRI is contraindicated, unavailable, or cost prohibitive. Additionally, ultrasonography offers advantage of providing dynamic imaging of meniscus, which when combined with clinical examination can enhance the diagnostic accuracy. However, it is important to note that USG alone may not be sufficient to determine tear. While it is highly effective in identifying meniscal cyst, it cannot reliably differentiate between traumatic and degenerative tears, and therefore it should be considered as a complementary tool to MRI, particularly in resource limited settings. These are the references that are used for this article. Thank you so much.